Hey guys, so today I chose that to talk about anatomical variants on neo MRI. The reason for this rather unconventional topic is that as I was reading on the neo MRI, there were so many variants that I'm sure most of them we don't know about it, and some of them are very similar to some disease processes that might gives us some confusion. So we need to know what's going on there. So first, the knee is the commonest joint to be imaged in MRI. We see knee MRI almost like every day, and all kinds of different tears and contusions and fractures and I don't know what. And it has a complex anatomy of bones, ligaments, menisci, tendons, and muscles. Each and every one of them is there are several anatomical variants involving them. So an anatomical variant considered present when there is a variable appearance of a structure that's always identified, but now it's identified in a different way, okay? Or there is a normal anatomical structure that may or may not be routinely identified. For example, regarding the bones, we have the most famous anatomical variant is the bipartite patella, which is separate patellar fragment, usually the superolateral aspect of the patella. It's about 2% and bilateral in 40% of cases. May occasionally sometimes be tripartite, sometimes multipartite patella, and you can see here. You can see here this small second. Okay, you can see here this small bony fragment here, and here with adjacent small bone marrow edema indicating some sort of mild contusion, but it's not a fracture, definitely. Again, here and here, and you can notice that when you add the two parts together, they make more than one patella. While in fracture patella, when you add the parts together, they just sit together like a puzzle piece. Okay, they fit together. So, could it be symptomatic? Yes, it can. It may be associated with anterior knee pain, and the MRI you will see some edema on the bipartite fragment and some fluid at the interface. Rarely it might result in traumatic avulsion. You can see here there is some signal hypointensity on the T25 saturated images. It's hyperintensity indicating bone marrow edema. Edema equals some sort of inflammatory reaction equals pain. So as an anatomical variant, it can be symptomatic. There is something called dorsal defect patella, which is defect in the deep aspect of the superolateral patella, and it's about 1% of the population. In the deep aspect, in the superolateral part of the patella, this defect. The trick is that the overlying cartilage is intact and fills the defect, and rarely associated with anterior knee pain. You can see here the overlying cartilage. It's intact, it's not interrupted, it fills the defect, goes into the defect and out, okay, indicating that it's not a fracture, it's not some sort of osteochondral fracture or osteoarthritis or things like that. It's just a dorsal defect patella, okay? Again here, we should zoom it like more, but if you look carefully, the cartilage is going into the defect and cover it. Okay, this is called a dorsal defect patella. It's a normal variant. The patellar shape also has different types. There's something called Weberg's type, Weberg's classification, which is depends on the relative size of the medial and the lateral facet. You can see the medial and the lateral. It's type 1, type 2, type 3. Type 1 is medial equals the lateral, or type 2, it's the medial. The medial is larger than the lateral, and type 3 it's very the medial is smaller than the lateral, and type 3 it's very small medial surface compared to the lateral surface. This type is associated with trochlear dysplasia, trochlear as in the elbow, okay? Fabula also another famous bone normal variant, sesamoid bone, located lateral to the at the lateral height of the gastrocnemius musculotendinous junction. It's about 13 to 20%. We see it very commonly. Well, there is something called fibula syndrome, which is composed of posterolateral knee pain over the fibula and osteoarthritic changes, even sometimes fracture of the fibula. You can see here it's this bone piece within the lateral head of the gastrocnemius on different anatomical projections and different MRI sequences. In the distal femur, there is something called distal femoral groove, which is seen in the anterior aspect of the metaphysis, and it corresponds to vascular channels supplying the bone, like this small dot here, this groove here. You can see these are not defects, not pathologies. These are normal, just anatomical channels, vascular channels, arteries, and veins supplying the bone. So when you see them, don't be worried that there is something wrong with the femur and things like that. It's just grooves, femoral grooves. Also, in the lateral condyle, you can see there what's called condylopatellar sulcus, sometimes seen in the medial condyle, and do not mistake it as osteochondral disease. Like here, you can see this, the overlying cartilage is covering it. It's not interrupted, so it's not an osteochondral disease or osteochondritis dissecans. Okay, this is called distal. Again, the distal femoral grooves, different kinds of grooves, just vascular channels entering the bone. Okay. Anomalous ossification of the lateral femoral condyle can happen, may mimic stage 1 osteochondritis dissecans, and the differentiation from osteochondritis dissecans is that it's asymptomatic. The location of it is not common for the osteochondritis dissecans. There is no edema and intact overlying cartilage. You can see there is some sort of what appears like a defect here. This is not a common site for osteochondritis dissecans. The common site is at the articular surface itself, the most common site. Okay, so there is no bone marrow edema. The overlying cartilage appears relatively intact. There is no defect. Again, you can see in this case, it's just like a lobulated outline of the femoral condyle due to anomalous ossification of the lateral femoral condyle. It's a normal variant. It's not a pathology. Regarding the meniscus is a very important thing to look and know the anatomical variants, because most common thing that we see is meniscal tear, meniscal buccal handle tear, meniscal defect, meniscal. So we should know the anatomical variants. There is something called meniscal fluence, which is a buckled meniscus, just a wavy or folded meniscus. The meniscus is just wavy. It's not straight like we normally see it. It's seen up to 6% of the knee MRI, and it's more common on the medial aspect, medial meniscus, and associated with ligamentous laxity. It can be transient, like in flexion and extension, gets pulled and no wavy appearance, while normally it can be seen as wavy appearance. For example, if you see this appearance here, you would say this is an abnormal meniscus, just folded. There is something wrong. There might be some sort of buccal handle tear, or I don't know, some sort of trauma. No, it's just normal meniscal fluence. It's a wavy meniscus. Don't worry, this is normal. Okay. Meniscal extrusion is another abnormality, or not abnormality, another normal variant, which is extension of the margin of the meniscus beyond tibial plateau. This we see a lot of the times. I'm sure you've seen it. Normally the anatomical the normal anatomy is to see the meniscus at the edge of the tibial plateau. Sometimes it gets extruded out of the medial of the tibial plateau. Of course, it's much more easily seen on the coronal images, and it's asymptomatic, 15% in the medial meniscus and 13% in the lateral meniscus. This is called meniscal extrusion. Keep it in mind. It's a normal variant. I'm sure when you know it, you'll see it a lot. We see it like every day, but if we don't take care, we just skip it. We don't know that this is a normal variant. Discoid meniscus is another type of meniscus. The normal meniscus is a semilunar, while discoid meniscus is a disc-like, thick. Okay, like here you can see this is a normal meniscus, commonly seen meniscus. It's a semilunar part. The body appears thin. The anterior posterior horn appears thick, while this bow tie appearance sometimes it's absent. It's just like a discoid meniscus. There is something called Watanabe classification for the discoid meniscus, which divides it into partial, complete, or Rizgary type, which is absent due to absent posterior capsular attachment. Partial it does not reach the intercondylar notch. You can see here it's a discoid meniscus, but it does not reach the intercondylar notch. The criteria for it is the minimal width in the coronal plane is 15 millimeter, and meniscus width less than more than 25% of the tibial plateau width. This is the tibial plateau width. You take the width of the meniscus. Sorry. You take the width of the meniscus, and it should be more than 25% of the tibial plateau width. This is a criteria for the partial discoid meniscus. Complete, it reaches the intercondylar notch. It's larger, longer, goes like that into the intercondylar notch. Much commoner laterally, about 3% of the population. Asymptomatic unless torn. And the Wisberg type, it's a hypermobile meniscus that can sublux, causing locking. Sometimes if it's subluxed meniscus, it's just not fixed in its place, resulting in locking of the knee, and the surgeon is looking for some sort of ACL tear, PCL, I don't know, like a foreign body or synovial floating something, and there is nothing of that. It's just a hypermobile discoid meniscus. Okay. Regarding the lateral meniscus, there is something called speckled anterior horn, which is a common finding due to fibers of ACL inserting into the meniscus. You can see the anterior horn is speckled. It's multiple dots, something just like salt and pepper appearance. Okay, it's just due to ACL fibers inserting here. Do not mistake it as a tear. It happens in 2% of all meniscal tears and 6% of lateral meniscal tears. You can see this appearance. Okay, it's not a tear. It's just speckled anterior horn. Okay, ACL fibers insert into the anterior horn of the lateral meniscus. Meniscal ossicles sometimes happens. It's commonest in young males and posterior third of the medial meniscus. It's some etiology is not very well understood. Some of them are developmental, some happens post-traumatic, and occasionally they might be symptomatic. You can see some sort of ossicle within the meniscus, okay, called meniscal ossicle. You can see this bone piece here and bone piece here. It's within the meniscus. Again, I don't know whether it's obvious on the data show. You can see some sort of bone here within the joint capsule with no signs of osteochondritis dissecans or things like that. So it's just a normal variant of meniscal ossicle. Other meniscal malformation, excluding discoid meniscus, it's only 0.3% and more common laterally. There are things like ring-like meniscus, which may mimic bucket handle fragment in intercondylar notch. It's ring, full ring, not semilunar. Okay. Sometimes maybe double-layered meniscus, abnormal lateral band, rare normal variants. Regarding the synovium, we should pay attention to what's called synovial plaque, which is just a folds of vascularized synovial tissue. It's just the synovial, the joint capsule is folding in the joint itself. Okay, it's from 50 to 90% incidence, and on the MRI, usually most obviously identified when there is knee joint effusion. When there is knee joint effusion, you see it easily. For example, you can see here this infrapatellar, like a membrane or septum or something. It's plaque. It's the commonest kind. It's curved course running from the intercondylar notch anterior to the PCL to the inferior pole of the patella. I think it's very obvious here. This is just a normal variant of synovial plaque. Don't get annoyed or no alert from this appearance. It's just normal. There's another kind of plaque called the mediopatellar, which is most likely to be symptomatic. It runs from the medial wall of the knee joint to the synovium overlying the Hoffa's fat pad, and there are 4 types described: A, small ridge; B, shelf-like. We will see the B, which is type C and D. Also, we'll see it just a second. You can see here this kind of plaque here. It's optimally identified in the presence of a knee joint effusion. You can see here, so you can see it here, mediopatellar. It's on the medial side. Okay, you can see it in the axial section also. This is synovial plaque. Okay. The type C, it extends across the medial femoral condyle, and type D is has central fenestration. This is the type C. You can see the medial femoral condyle, it extends just like that. And type D, it has a fenestration, has opening inside, just a hole inside, okay? So type 3 and 4 are more likely to be symptomatic, resulting, which is due to impingement between the medial femoral condyle and the patella. It just get stuck there, okay? Also, there are suprapatellar plaque, like this one, which is an oblique membrane located just above the patella. I'm sure if we see this a lot of times. This suprapatellar plaque. Okay, the suprapatellar plaque can be complete, results in separation of the suprapatellar bursa, or sometimes an inflammation may mimic a soft tissue tumor. You can see here. This is a synovial plaque that is inflamed. It's get thick, get edematous. You see it, you think, is that a tumor, some sort of soft tissue mass, something like that? No, it's just a plaque that's inflamed. Okay, so you should keep it in mind. Regarding the ligaments, there are a lot of variants in the ligaments. The most important ones are oblique meniscal ligament, which runs obliquely through the intercondylar notch between the ACL and the PCL. Okay, you can see it in the intercondylar notch between the ACL and the PCL, anterior horn to the contralateral posterior horn. It's oblique. The anterior horn to the opposite posterior horn. Okay, it's more obviously on the medial side, and it's prevalent up to 4%, may mimic free meniscal fragment. Okay. Another kind of ligament is what's called meniscofibular ligament. You can see it running from the meniscus, posterior horn, to the fibula, the lateral meniscus, of course. Capsular ligament extends from the posterior third of the lateral meniscus to the fibular head, always present in dissection specimen. However, on the MRI, we see it in from 16 to 63%, depending on the slice thickness and the presence of effusion. This ligament here is just a normal variant, normal ligament. Don't think that this is some sort of tear or meniscal fragment or things like that. Fabulofibular ligament, from the fibula to the fibula. Okay, fabulofibular. This ligament here. It's identified up to 80% of dissection specimens and 48% of the coronal oblique MRI studies. Keep it in mind, it is not some sort of pathology, it's just a normal variant. Okay. Popliteofibular, again from the name, it's the popliteus muscle to the fibular head. Almost always present dissection specimen in up to 50% of the coronal oblique MRI studies. It's seen, also commonly identified on the sagittal MRI images. You can see it here. Popliteus to the fibula. Popliteus muscle to the fibula. You can see this is the tendon, the popliteus extends to the fibula. It's attached like that. Meniscofibular ligament again extends from the posterior horn of the lateral meniscus to the medial wall of the intercondylar notch or to the PCL. Okay, you can see this black dot here. This is the meniscofemoral. It extends from the meniscus, from the posterior horn of the lateral meniscus to the medial wall of the intercondylar notch. Okay. It's very common, presented up to 93% of population, and there are several studies, for example, on Humphrey study seen in 12% and Rizgary seen in 42%. There is also the meniscofemoral ligament can be prominent, called prominent ligament of Humphrey, may mimic double PCL sign. This one, you can see, it looks like a double PCL sign, which indicates a bucket handle tear. But keep in mind, it can be a meniscofemoral ligament that is prominent. You can see it on the coronal and on the sagittal images. Okay? It's not a double PCL sign. There are no other signs to support this diagnosis. The meniscus is intact. There is no joint effusion. There is no, the clinical features does not go with the bucket handle tear. So how would you explain it? It's just a prominent meniscofemoral ligament. Also, the meniscofemoral ligament can be anteromedial meniscofemoral ligament. It's a rare type, rare normal variant. Runs anterior and parallel to the ACL. It's just like a double ACL, not double PCL, double ACL. It's not a pathology, it's a normal variant, arises from the anterior horn of the medial meniscus. Okay? There is something called transverse intermeniscal ligament. As its name indicates, it's between the menisci, between the two menisci. Okay? If it's more than 3 millimeter in thickness, it will appear thick and cord-like. This is not a lesion, not a pathology, not a meniscal fragment, not a meniscal tear. It's just a ligament runs between the anterior horns of the medial and lateral meniscus. Okay? Posterior cruciate ligament usually it's smoothly curved, but may be kinked. I'm sure we've all seen this appearance. Kinked at the genu. Also, the posterior cruciate ligament has two bundles, anterolateral and posterior-medial. You see separately on MRI, this is called double barrel PCA. It's just like a double barrel shotgun, two double ligaments. Okay, you can see it here. This and this, two bundles. I'm sure it's obvious. Double barrel. This one and this one. It's not two ligaments. It's two bundles of the PCL. Okay. The posterior cruciate ligament has oblique fibers, sometimes, may obliquely insertion into the medial femoral condyle, commonly seen on MRI, may be mistaken for a meniscofemoral ligament. However, both of them are normal variants. As you can see here, this is an oblique fibers inserting into the condyle. Regarding the tendons, we should keep in mind there is the popliteus tendon. Popliteus muscle, as we know, is a major stabilizer of the knee joint. It's a small muscle that is very, very important in the knee joint stabilization. So the tendon of the popliteus muscle, you should keep in mind that it should be always present, and it's not a pathology. It's in fact very necessary for a normal functioning knee joint. Extends from the popliteus musculotendinous junction to the lateral femoral condyle. Bifurcate popliteus tendon reported in 0.4% of the knees at arthroscopy. You can see it bifurcate, like separate. The quadriceps tendon formed from combination of, I'm sure everyone knows, the rectus femoris, vastus lataris, medialis, and intermedius. It's a multi-layered structure. You can see it as a single tendon, you can see it as a double, as a triple, and as quadruple. Okay, for example, you can see it here as single, you can see it as a double, you can see it here as multi-layered tendon. All of them are normal appearing quadriceps tendon. Regarding the patellar tendon, which is in fact the same tendon below the patella, the same quadriceps tendon, it can be buckled, which is relatively common, and especially when with erect imaging. You can see it buckled. It can be straight like this or buckled like this. It's not very well straight. More commonly seen with joint effusion and ACL rupture, because there will be joint laxity resulting in buckling of the tendon. Okay, it becomes wavy. Also, the biceps femoris tendon. Biceps femoris distally insert typically into the fibular head as part of the conjoint tendon, and sometimes it has separate insertion into the lateral tibial condyle, is commonly seen. Like here you can see the biceps femoris, it's inserted into the fibula, commonly. But sometimes you can have a separate insertion into the tibia, resulting in some sort of abnormal appearance. Don't be confused, this is just an abnormal or not normal variant insertion of the biceps femoris tendon. Also can have a predominant insertion into the tibia or the tibial plateau. You can see here, this is the biceps femoris tendon, and it's not inserted into the fibula. It has no relation to the fibula, it's inserted into the tibial plateau exclusively. Okay, and this can result in a painful snapping knee. It's a normal variant with some might result in symptoms. Okay, the semimembranosus muscle, it has multiple distal insertions to the proximal tibia, posterior capsule, can have intratendinous fat which might mimic partial tear. You can see here, this is the tendon of the semimembranosus muscle, and there is a hyper-intense signal on this T1 weighted image, which is just a fat. It's not a hemorrhage, it's not bleeding, and I'm sure we can easily distinguish that this is just a fat by any T2 or T1, any fat saturated image. In fact, it will disappear. Okay. There is something called the articular muscle. Sorry, articular muscles almost always present. They originate from the anterior shaft of the distal femur and inserted into the suprapatellar notch. Okay, from the anterior shaft of the femur into the suprapatellar notch. It has a variable size, can have single, multiple bundles, can be prominent, can be ill-defined, small. Its function to retract the suprapatellar pouch in the knee extension. When the knee extends, the suprapatellar bursa becomes folded. Its function is to tighten it, to make it tight, حتى, يعني it does not get impediment. Okay. So you can see here, this is an articular muscle just within the synovial joint, from the anterior shaft of the femur into the synovial capsule. The sartorius muscle is another muscle that has distal insertion, may be predominantly tendinous or muscular, and the distal tendon might bifurcate. You can see here, this is the sartorius muscle. The tendon can be bifurcate, like here you can see. Okay. There's something called accessory gastrocnemius muscle. Accessory gastrocnemius muscle, typically, you know, the gastrocnemius muscle has medial and lateral heads arising from the posterior femoral metaphysis, medially and laterally. Sometimes it has a third head, 3 heads of the gastrocnemius. Accessory head, up to 5.5% of the population, may cause popliteal entrapment syndrome. You can see here posterior distal femur, 2 lateral head. Okay. You can see this one is an accessory head here. You can see this, there are 2 heads and an accessory head here. Okay, you can see this is just another muscle. It does not have any anatomical basis, some sort of muscle in between. Okay, this is an accessory head of the gastrocnemius muscle, 3 heads. Okay. Accessory popliteus also might be seen sometimes, which arises from the fibula and inserts into the posterior proximal tibia. Can be seen separately as an accessory popliteus muscle, another muscle, or you can see it arising from the original popliteus muscle. Okay, plantaris muscle, it can be absent in 10%. It has multiple origins and insertions, thin and fibrous to bulky muscle belly, can be thin, can be bulky. The plantaris, I'm sure if you remember, it inserts into the plantar fascia, the foot. Okay, it can arise from the knee joint. It can be as long as that, from the knee joint to the foot. Very long plantaris muscle. It has a role in the function of the foot. Okay, keep it in mind. It might be bulky sometimes. Okay, these are the most important anatomical variants that we see in the knee joint. I hope it was beneficial. Now we know most of them. I'm sure when you see knee MRI, you will find some of these variants and you will remember, this we know about it now, this we know about it now. It might look like a pathology, but it's not. Okay, sometimes might cause symptoms even though it's a normal variant, so you should report it at least. There is that normal variant, it might be the cause of the patient's pathology. Thank you very much.